This nation had been very successful in fighting tobacco and smoking. The second epidemic is obesity. And my question for you is, why wait? There is a lot of programs, there is a lot of academia interest in many of these interventions and innovations, and also there is commercial side that also did a lot of wonderful job. So we are here in DC and would like to find people here who come in and thread all this wonderful work and this wonderful innovation. Thank you again for attending this session. And I would like, before I leave, to introduce the second moderator for the next session, Mr. Andy Weber, and he is from the National Business Coalition for Health. Thank you very much and enjoy the next session.
Great, and I'm going to have my panelists come up here and take a seat. We're a little challenged. We don't see you on this side, so we're going to move over to the left side of the room. Delia, why don't you sit here? And Paul there, and Brent there. That's great.
Hi, Delia. How are you? Nice to meet you.
Well, good morning, everyone. I'm Andy Weber, President and CEO of the National Business Coalition on Health, and we're all here representing the business community and the employer perspective in health and healthcare. The National Business Coalition on Health represents 56 employer-based coalitions. We heard from one of our members today, the Northeast Business Coalition on Health, Jeremy Nobel. We are focused, as we all are, I think every stakeholder, on the challenge of improving health and healthcare and how to get to the final issue that Sam Ho raised this morning, and that is affordability. And I think I speak for our colleagues on the stage that the road to affordability for employers, for individuals, for government, for our country at large, the road to greater affordability is really through the path of both getting to improve population health. How do we improve the health status of the American population? Why is it that we rank 37th in the world in healthcare status among industrialized countries? And then secondly, how do we transform the healthcare delivery system to not only make it more efficient and cut out the waste, but how do we move it towards a system that focuses more on prevention and chronic disease management as a goal, rather than a system that's focused on just treatment of illness? And the issue that we're going to be talking about today, and perhaps has not been a perspective that we've heard a lot about at this conference so far, is what is the role of the business community? Why are employers in this game of health and healthcare? Broadly speaking, but also as our focus of the conference is on diabetes, specifically focused on how do we both prevent diabetes. I think, again, my colleagues would all say that our job number one is to prevent illness. Every sick employee is sort of a failure of the system. How do we prevent diabetes, and then how do we better manage diabetes? And can we get to those endpoints? So with that, and our session, we got a very provocative title for our session. Our session is U.S. versus Diabetes, the battle of the century, establishing a business or employer gold standard for diabetes prevention and management in the workplace. And again, we had a little prep call, and we'd like to broaden that, again, from an employer perspective to what is the business gold standard for disease prevention and health management in the workplace. So with that, I'd like to introduce my great panelists. To my left, Delia Vitter, Senior Director of Benefits and Programs at EMC Corporation. Delia has been with EMC since 1994 and really represents a senior official in charge of health benefit strategies for her corporation for many years. To my right is Dr. Brent Policki, Chief Health Officer for the Goodyear Corporation. Been there since January 2011, so it's a recent arrival to Goodyear. But those of us in the employer community have known Brent for many years in this space and was previously corporate medical director at Pitney Bowes. Pitney Bowes being a true leader in health and healthcare within the employer space. And Brent, you can talk about both the experience at Goodyear and at Pitney Bowes if you want as part of this conversation. And obviously, as Chief Health Officer, Brent really does represent the health office within the employer community, health and safety being an important corporate responsibility that Brent heads. And then last but not least, and really representing the C-suite, we are so privileged to have Paul Sperenza, Vice Chairman, General Counsel, and Secretary with Wegmans Food Markets. Paul has been with the company since 1976, which is a long time. I don't even want to tell you where I was in 1976. But anyway, Paul has been, again, a C-suite leader, and Wegmans has been particularly active at a community level, so we're going to be talking about that today. And a point of personal privilege, Wegmans is near and dear to my heart because my wife is from Rochester, New York, so I've been to very many Wegmans stores around the country. They're now in the Mid-Atlantic, actually, in Virginia, so they're growing around the country. And I just have to tell you a very quick story. My wife is Ukrainian American and had family that was in Ukraine. And finally, through the breakup of the Soviet Union, her family was able to come visit in the United States. And so the first trip was, of course, to my father-in-law's in Rochester, New York. And one of the first trips we took with those relatives was to a Wegmans store. And they walked through the Wegmans store up and down the aisle in disbelief. In fact, at the end, they were in tears. They were crying because they could not believe that there was such access to anything that you could possibly imagine. When the story in the Soviet Union was, of course, America was a poor country, and again, to see the reality of it was amazing. Anyway, just a point of personal privilege there. Anyway, it's a great panel. We've got about an hour for conversation. Again, it's going to be a little broader than just diabetes. And my softball question to start us off is, why does the business community care about health and healthcare? What is their motivation? And why are employers, the business community, in a good position to influence health and healthcare as a core strategy? And I'm going to start with Delia to start us off.
Great, thank you. Great question. So why do employers care about the health of the population? It's simple. It's shareholder value. Continuing to increase shareholder value, the sustainability of a corporation. I know for us, in our journey over the past 10 years, it's been focused on creating a healthy workforce, a healthy environment to help employees and family members manage their health through very targeted and meaningful programs. And I think the important thing is that we focus on healthcare cost savings or cost avoidance. There's also another aspect of health. Oh, can you hear me now?
Mm-hmm.
Oh,
yeah.
Oh, I said all those things for nothing?
No, you didn't. No, I think it's the mic just needs to be maybe a little lifted or something.
Right.
Yeah.
So I won't bore you with the details of my first introduction, but At EMC, our focus has been on creating a culture of health and health management for the long-term sustainability of EMC, but also from a cost perspective, not only for EMC, the corporation, but for employees as well. And one of the key things that we'd like to remind our employees is that healthcare is a shared responsibility, and we all pay for healthcare. It's a societal issue, and it's a corporate issue as well. And we'd like to gauge our employees' thinking that if we create a culture of health and we manage our health and there are interventions that are available to employees and family members based on their chronic conditions, that pool of healthcare expenditures will not increase as quickly. And we'd like to remind employees that they pay a portion of that large pool of money that's paid in healthcare. As an example, $235 million of EMC's dollars are paying for healthcare. Our employees pay about $44 million of that 235. And we remind them that containing those costs contains their out-of-pocket costs as well in the area of cost shifting as well as employee contributions. So our programs have been very broad. We focused on certain programs at a very narrow level, but also it's been very broad in using data analytics to drive our programs and to drive also the success and the engagement of our programs. So very focused on understanding our workforce, and understanding our workforce starts with data so we can drive the right programs. So creating a culture of health is the long-term sustainability for our company.
Great. Brent, and because we only have an hour, if we can be concise, pithy, and brilliant, that would be great.
Well, ultimately, what we want to do is to have healthy, engaged, and productive employees. And those folks are going to be spending money on healthcare. When people are not healthy, they actually are more at risk for spending more money, as well as at risk for more workers' comp injuries. So those are some of the things about why we care about that, because we do have shareholder value, but we do want our folks to be productive. So Andy mentioned that about a year and a half ago, I actually moved to Akron, Ohio, from New York City. And not only was it socially awakening, it was also quite an awakening, because as all of you think about the CDC's obesity graph of the United States, the map, it's in all your lectures. I know you've given it. Think about Gadsden, Alabama, Fayetteville, North Carolina, Lawton, Oklahoma, Houston, Texas, Beaumont, Texas. These are the places where we have plants. These are the sickest of the sick people in the United States, and those are the ones that are our employees. So what we have to do is to figure out how do we get them to be healthier, because the issue, if you look at the research from Dr. D. Eddington from the University of Michigan, he has a graph that shows that as people age, not surprisingly, their healthcare costs go up. But as you add increased risk scores on top of those, they increase exponentially. So our goal is going to be, how do you keep them at that lowest level without increasing the risk scores, because it's very difficult to bring them from a high risk score down to a low risk score.
And Paul, you're chairman of the board or chair of the board, and you have board conversations. Does health and healthcare come up in sort of C-suite discussions and with your board, and in what context?
Absolutely. I would say first, we view ourselves as a healthcare company. Nutrition is one of the things we've heard about throughout this whole process, and we'll get to that in a minute. Just taking a step back, each and every one of you are also employers. So I agree with everything that's been said to date, so I won't add to that. But our view from a philosophical standpoint is our employees always come first, and we mean it. And our view as a privately held company, if we truly put our employees first, our employees then take care of our customers, and if our customers are taken care of, the bottom line takes care of itself. And a key component of that is the health and wellness of our employees. And the one thing I'd like to share with you, if you truly mean that, what we take particular pride in, yes, we're a cutting-edge retailer. Fortune magazine each year lists the top 100 companies to work for in America. And we have fortunately been on that list each year. For the last 8 years, we've been in the top 5, and no other company in America has been able to do that. And the reason we're so proud of that is 70% of the scoring comes from random anonymous surveys of our employees, part full-time, manufacturing stores, office, distribution, et cetera. How do we get there? And we'll get back to it later, is if we truly believe in our employees one-on-one, healthcare wellness is a key component of that, and we talk about that all the time in our C-suite.
So the next question is, can you measure the health and the disease burden within your population? It's sort of a principle of continuous quality improvement. You can't improve what you can't measure. So, so do you have a sense and a profile, and do you invest in measurement systems that look at your disease prevalence, that can track your healthcare costs? And there was a question from Jeremy this morning about even tracking the indirect costs of the burden of illness on lost productivity, on absenteeism, on disability insurance costs. So the next question is, you know, I often think of an employer as a provider. You've got a defined population, your workforce, your dependents, your retirees. If you provide benefits, you've got that defined population, and you need to understand their issues before you can then move on to intervention strategy. So talk about that a little bit, Delia, the sort of data and measurement of your population.
So we've measured a couple of programs.
You need to use the mic. Yeah.
Okay, sorry. We've measured, first of all, we're continuously measuring our programs, and we measure it on a very aggregate level of engagement in the total suite and array of health management programs that we offer our population. And based on that, the trend, so for employers, bending the trend is absolutely key to getting reinvestment in your programs. For EMC, over the past 10 years, we've contained, in total engagement of our population in every program, we've contained over $300 million in expenditures over a 10-year period. That's at a very high level. At the more granular level, we've measured a couple of programs. Hypertension, we conducted a study with Boston University and Medical Center, and we measured our population over a 2-year period that participated in the DASH program, which is Dietary Approach to Stop Hypertension. And the cost savings and avoidance of the individuals that stayed in the program for 2 years and we could follow their claims was nearly $1,000 per individual. And we did something similar program with the remote patient monitoring for hypertension and the intervention group versus the control group. And we saw a return on investment of about 3 to 1. So metrics are key for an employer because that's how we can get funding for our programs and continue to reinvest. So it's, but it's data and it's a lot of work.
Brent, your comments?
We use a data warehouse that has been gathering the data for all the health care claims, all the workers' comp claims over a period of time. We as a company don't know anybody's individual results, but we can get some rolled up results so we can understand what the costs are and what are the conditions for folks at individual locations. So one of the things we've been able to do is to take that data and to look at it at each individual location where we are, and really determine what are the challenges and the risks, so we can actually get a risk score about what is the health of the population. Now, interestingly, when I took that risk score and then I put on top of it the actual healthcare spend at each of those different locations, it's pretty amazing how it tracked almost identically with the risk score with the actual spend of the population. So it's been eye-opening, and in fact, I put it all on one slide, and I sent it to one of my senior executives. Somehow, he forwarded it to everybody on his management team because it actually spoke a lot about the health of the company. Now, the challenge with that data is that we don't yet know, if they haven't accessed the health system anywhere, we don't know about those ticking time bombs who haven't done any preventive care or accessed the healthcare system at all. So we've had to do some things to try to get at that data as well. So we've put together a health risk assessment in order to do that, and right now we're incenting our population to be getting their biometric data so that we can actually know what is an individual person's health. Not that we know what it is, they know what it is, but then it gets gathered up so that we can truly understand the health of our population.
So Paul, do your folks, do the head of benefits, do your health officers come to you with information on the health status of your population? Can you track it and trend it over time?
Absolutely.
And again, is that an issue for the C-suite?
Absolutely. We look at it in two ways. Number one is we track our costs, and we've created over the decades a culture of wellness within our organization. Just give you one example. We developed a program very similar to ones that you may have called Eat Well, Live Well. It's walking 10,000 steps a day, encouraging our employees to eat 5 cups of fruits and vegetables, very simple. But we turned it into a competition because Americans always love to compete. And we found that to be very successful, and tens of thousands of our employees participated. We pitted store against store and department against department, division against division, and that's just a start in terms of wellness, and I just use that by way of example. So the first thing is what we drive through our company, and we look at overall healthcare costs. The second thing we do, because we can't do it alone, we took a successful program and we drove it through our entire community. Rochester has about 1.1 million people. And so we reached out to other employers, Kodak, Xerox, Bausch & Lomb, Rochester Institute of Technology, Paychex, Jesco Tools, worldwide 200,000 employees. So we took these programs and ran them through the community. And this, along with other programs that we've been working on as a community for a long time, many collaborations. We look at the bottom line for our community because it's just not only business, but the communities where we do business. Currently, our health insurance costs are 30% below the national average. According to a 2010 Milliman study, our Medicare costs, according to the Dartmouth Atlas, is a community of 1.1 million people, or 21% below the national cost. And even before the Affordable Health Act, our access to health care in our community is uninsured is at about 6%. And we stress collaboration. We've done it for years. One last thing. Rochester received the largest CMMI innovation grant in America, partly because of the collaboration of all these stakeholders. We'll talk about that a little more, but it's not just businesses, it's our 3 hospital systems, our 2 health insurers, all coming together around this, and we measure it all the time. It's just a key part of our business. We can tell you just the way we do that, just as to how many tomatoes we sell each day.
And Paul, I promise we'll get to community level interventions. My friend and colleague Ann Albright is in the room, so I have to ask the question whether, I'm sure you measure your diabetic disease prevalence, but do you measure your pre-diabetics? You know, that is, again, the tsunami. We heard about evidence-based strategies to influence the pre-diabetics. Through a little bit of intervention could really have a profound impact. So just very quickly, is that part of the strategy, or are you thinking about it, perhaps? Delia?
Yes. Can you hear me okay?
Yeah.
Oh, great. Yes.
You hear that, Ann? Yes.
Yes, absolutely. We focus very much on prevention, and not just on prevention and covering office visits for wellness visits, but particularly on-site prevention. So we offer our employees at a national level on-site screenings, biometric screenings, where there's biometric screenings, there's screenings for diabetes and for hypertension. And what's interesting is that we found quite a few at the onset of diabetes and hypertension. So that was absolutely key. And so, and then focusing on programs to help the individuals manage those conditions. So yes, prevention is number one and very important.
Great. Brent, you want to add anything or move on, or? pre-diabetics?
We actually are gathering that data now with our biometrics, so I don't have it before November 5th.
Great, but it's part of the agenda. So we're motivated. It's a business imperative. We're collecting information. We understand our population, their disease prevalence, where costs are going. And the biggest challenge I hear is always, Andy, so what do we do? What are the evidence-based intervention strategies that are part and parcel of a health promotion and disease management strategy for a company? And of course, I'm sure all of you have a host of programs, but I'd like you to focus in particular on anything you're doing on diabetes, because this is a conference on diabetes prevention and management, and also talk about the issue, back to metrics, of impact. How do you measure and evaluate the success or failure, because there's a lot to learn from failure, of your intervention strategies? So Delia?
Sure. So for EMC, we spend $1.8 million a year on diabetics. That's about 0.8% of our claims and 2.8% of our members. And what we found is that 50% of the spend of diabetes is on type 2 diabetes, no surprise. And our compliance rate, though, for our diabetics is actually very good. When we measure ourselves to the national standards, at EMC we're about 70% compliance versus I think it's 60 or 62% nationally. So as we continue to look at the population, sort of pre and managing those that are diabetic, many programs come to mind. So lifestyle coaching, disease management, obesity programs, both for children and for adults, which those are all prevention of, or help to prevent and manage diabetes.
And Brent, again, with your Pitney Bowes, I want to ask you in particular, any value-based benefit strategies? So we, of course, all learned from the Wall Street Journal the whole program at Pitney Bowes of coaching and counseling, but actually, again, based on an assessment of the population and identifying a problem with adherence to appropriate medications for diabetes, and I think it was a few other disease, the benefit design strategy to actually reduce copays, maybe even waive copays for, again, high-value services. So maybe you can talk a little bit about that experience as one of the intervention strategies that we think employers are deploying.
So back at the time at Pitney Bowes, Dr. Jack Mahoney was the person in charge of benefits who had this idea that said, if you keep people well and you give them the stuff and you get rid of barriers, can you make a difference for folks going down with their health? So for two conditions, for diabetes and for asthma, he said, let's take any drug, brand name, generic, whatever. If it's used to treat asthma or diabetes, let's get rid of the copays for those, and let's make sure that people can get them, and let's take away whatever barriers are there. What we found at that time was quite surprising, actually. First off, the consultant said, you're crazy, you're going to lose all this money and all that other thing. But more importantly, what we found after that first year or so was that actually compliance got better, the healthcare costs got better, and people were healthier. So that really was the foundation for a lot of the work that a number of other companies now are doing around value-based benefit design.
It certainly has. I know in our program we've got many of our coalitions that, working with their employer members, have implemented value-based benefit design strategies. It's part of our interaction too with healthcare plans. I'm looking at Sam Nussbaum in terms of working with plans on benefit design strategies, and we're about to ask a specific question too on incentives as a motivator. But Paul, any really effective And again, work site-based programs before we move into community-wide efforts?
Sure, Andy, as we talked about before, we've worked very hard to create a culture of health, and one of the things that we do, because we're in a unique situation, is we have pharmacies in all of our stores. And so in coordination with physicians, we've done first a major Know Your Numbers campaign. So out of our 44,000 employees, 28,000 know their numbers across the board. So that's a start. You have to know your numbers before you can do anything about it. Number two, we've spent a lot of time learning about what it takes to have sustained behavior change. And a key element to that we find for us are pharmacists, developing a one-on-one relationship with our own employees, encouraging them. There is no silver bullet, there is no one answer for all of our employees, but developing a one-on-one relationship, a trusting relationship. And it doesn't matter what the disease state is, whether it's hypertension, diabetes, if you have the relationship, the pharmacist, fellow employee, encourages the individual employee to go to their physician, be part of the team that you've heard about before. And we think that's one of the things a little bit unique about us, because we do have pharmacies in all of our stores.
That's great. So we're going to pull up the ARS question. Is it, I can't see the screen. And ask the audience, before we get into a little discussion of incentives, a big controversial issue within the employer community, the use particularly of financial incentives as a motivator for behavior change. So here's the question: which do you think is more effective in changing lifestyle habits? External rewards, financial incentives being the key one here, and then internal rewards. And a little editing here. I would really talk about this as intrinsic motivation as the catalyst rather than a financial incentive. So you can answer with either a 1 or a 2 on your technology, and vote now, please. I love classical music. This is great. Okay, can we bring up the, look at that. Very much divided. And I think that's the debate that we're hearing, is certainly among the employer community. I'm certain in your circles as well. So let's talk about use of incentives as a motivator. Delia, is it part of your program? Do you think it works? What's your sense?
Yeah, I think absolutely incentives are part of our program. You know, does it work? I fall into the number 2. I think it's sort of a, you know, something that you do so you can feel better and look better. So I'm not very big on providing incentives just to take a particular action, because I just feel that that's a point in time, and once you have that incentive, you're done. But what we're finding is that generally incentives work at least to get you started. We have 90% of our population that's completed the health risk assessment, and that's the beginning of their journey into health management. And we hear a lot of different things. Sometimes, because there's a discount in employee contributions, so if a spouse and an employee both take a health risk assessment, it's a 12% discount in employee contribution, so not bad. And we find that some people say, oh, I'm just going to do this and I'm done, just so I can get my discount. And they may not, engage. That's a certain percentage. And then we find others that really find value in seeing that they're, how they rate against others, within the company, because we do chart the scores. And it gives them a little bit motivation to get started. So I think incentives work to some degree, to just sometimes just get you over the edge a little bit. So we are focused on incentives, absolutely.
So to paraphrase, it's perhaps not a long-range solution, but it's sort of a catalyst to sort of get people started, and then hopefully the other motivation kicks in, right?
Exactly,
right.
Yes, yeah, absolutely.
Okay, Brent, at Goodyear or Pitney Bowes?
So Pitney Bowes used incentives quite well, and what they found was that you had to evolve them over time. So if you were doing something for a while, you can get them to do things, but it eventually starts to fall off. So when I started at Goodyear, the incentive was for people to make a pledge that they didn't smoke. That had been in place for quite a while. it was time to start evolving that into something else. So we evolved first for people to do their health risk assessment, and this year it's about getting their biometric testing done. We have a unique study going on right now, not by design, but because some of our population is eligible for the incentive, some of it based on the collective bargaining is not. And what we're finding is that those who are incented have much higher participation rate under the biometric testing than those who do not. So it's not played itself out fully because we have till November to get this done, but we're seeing the early results that incentives do matter.
Paul, your comment?
Sure.
Weighing in on this?
Absolutely. I'd like to take it back to a community perspective because I think that's where this fits best. We had some of the people in our group, the representative of Paychex and Xerox, actually went out to our community and interviewed scores of physicians, health providers, et cetera, as to, we created this infrastructure over a 7-year period of time. What should we look at next? We picked high blood pressure first, and the reason for that, it's easier to measure, it's easier to talk about, and it's easier to control with medication. In any event, we reached out to our community, and we currently have 119 high-level volunteers from 60 different organizations. You can't get work done in large groups like that. We've broken down into 10 work groups, and I'll tell you just one. We have one around sustained behavior change, and just serendipity, the University of Rochester Medical Center has some world-class experts in sustained behavior change. So we've been working closely with them. And their view, and it's become our view, is that the intrinsic incentives work better in the long term. And their view is that if you can find a way, as I've said before, there's no silver bullet, but what resonates with an individual at this particular point in time, whether it's they want to look better for their child's wedding, or they want to live longer, or whatever it happens to be, that would be a better approach long term than if you do a financial incentive. The financial incentive seems to create change only for as long as that financial incentive exists. Mm-hmm. So at least for us, not to say that we don't do financial incentives, because we do, but we think the more important thing, and going back to what we do in our own company with pharmacists, we use that same approach with our pharmacists, and we've had them work also with the behavior change experts at the university about what resonates with each individual. So that's how we've been able to close the loop.
Right.
Andy, I'd like to jump in
Sure,
for a second.
yeah.
One of the things I think that's very important is that we in the health industry think that if we just tell people what's going to happen and they're going to live longer and they're going to feel better, everything will be fine. But we've heard from two masters of this yesterday. We heard from McDonald's and we heard from Walmart, who really do understand about how to reach people and to figure out what are the intrinsic motivators. And if you think about this brown fizzy drink that's sweet, there's nothing inherently good or bad about that drink, but when they're sitting on top of a mountain singing and you've got Santa Clauses coming down, that's what makes it warm and fuzzy, and that's what people connect to. So how do we get that message? And our widget that we're selling is health information. Think of it as a product. We have to start thinking about what we're trying to get across as the product of health information. How do we then help that resonate with our individual patients so that they then take that on and do make that more intrinsic type of a motivator?
And Brent, is one of the paths to that, and it's been a theme of this conference, this discussion, is the creative use of technology. Technology as a catalyst. We've talked about incentives, but the new technology that can both be reminders for provider delivery systems, but also can be a nudge, a reminder, a play to the subconscious for individual consumers. And we all know that it's changing consumer behavior, particularly when it comes to management of disease, that is much more of a key influence on getting to better outcomes than the interventions from providers. Sorry, all providers out there, but the 8-minute visit is not much of a motivator. We really need to get to what are the key triggers for individuals in living healthier lifestyles and being adherent to medications and in terms of exercise, all those things that, quite frankly, I don't think the healthcare delivery system has been focused on or has been rewarded to do. That's part of the reform. But let's talk about technology interventions as a catalyst. Anything, your views on that, Brent, starting with you?
There are many new technologies that are coming out. I think what they have to do, if they're going to be successful, is they have to relate to a person as they're going about their life. So it has to be there, but it also has to be something that people want. And I actually think more about low-tech things make more of a difference. So if we can build defaults in for folks, we'll be able to make a difference. So an example, in our cafeteria where we started, by the cash register, they used to put the pies and the cakes and things like that. So I said, what happens if we simply move it to, actually it was as far as where Delia is, and it wasn't in the person's eye. And literally they went from baking 4 pies a day to 1 pie a day. Nothing else changed than that. These are the types of things that we need to figure out. How can we build in these defaults for folks so they are doing the better choices and help them with building those choices? So whatever technologies are there, they really should help to support the better choices or helping people along that path.
Delia, are you dealing with any technology vendors or solutions as part of your overall health management strategy?
We are.
Good.
And, well, we're very focused on technology, and I completely agree with you that it's you need high tech and you also need high touch as well. So we focus on both. But our technologies are very centric to the consumer or to the employee. It's technologies like a personal health record and remote patient monitoring devices that are built in where employees can monitor their blood pressure and other conditions. The delivery of messages, alerts within the system that we focus on. We're technology companies, so that's how our employees engage and learn. But I've also noticed that they like the high touch as well, so you have to have a good balance of both. Employees often ask for face-to-face workshops. We offer workshops on a regular basis, and many of the times it's virtual through a virtual environment, and attendance is better in a virtual environment. But then there are the employees that ask, I'd like to have the speaker in front of me where I can ask my questions and actually have a person. So I think it's a balance. We all love technology, in our apps on our phones and our iPads, but we also like the personal touch as well. And another interesting, tidbit of information, you mentioned moving the pies across a little bit across, and we've done some of that as well. And also in our salad bar, we have color-coded the salad bar. So, when I make my salad, honestly, I think it's more calories than if I had a sandwich because I'm piling everything on top. But now the salad bar is color-coded, red, green, yellow. And it's changed behavior of employees and what they're putting onto their salad, including the salad dressing and so forth. So those little nuances work very well, and those are high-touch nuances.
Paul, any comments on technology?
Sure. First, starting with low-tech. We believe as a community that the personal touch makes the most sense and you get the most impact. So what we've driven to the community, what the experts tell us, you have to meet people where they are. They're not going to come to you. So we have programs in the workplace that we've worked on where we actually have employees working with and teaching other employees. We have programs in places where churches, for example. We have programs in beauty shops and barber shops. We have programs in retail settings. So every place where somebody might go, we do that. And then the key thing with respect to technology, high touch, unless you have a lot of volunteers, and we happen to have that in Rochester, can be very expensive. And so where we fit in technology is if you get things started with a one-on-one relationship and you try to motivate, where technology can fit in and begin to control and cut the cost is Rather than meeting with a human being each time, one of the things we might do is intervene and have, whether it's telephone, computer, et cetera, it cuts the cost over time. But we believe you have to start with the human touch first, and then technology comes second, not the other way around.
Great. So let's get into the community theme a little bit here. And my tee up for this is an employer leader saying to me, Andy, you know, there's limits to what I can do as an employer. Yes, I have a captured audience. I have them 8 hours a day. I can build a culture of health within the silo of my organization. But what happens when I lose that employee to a very unhealthy community? An unhealthy community that has poor schools, or violent streets, or food deserts, or a broken healthcare delivery system that doesn't have a primary care base, that has, you know, few parks, recreational facilities for kids to play, no sidewalks to walk to schools, no bike paths for folks to exercise. So as someone said before, you know, the default is the easy, is the healthier decision. So I lose them to community, and it sort of compromises all the investments that I've made. So the big question is, what is, you know, you said at the very beginning that employers have a responsibility to influence their workforce. But do employers, and Paul, you've certainly been suggesting this with all your remarks, but I want to get Delia and Brent to weigh in. Do you also have a responsibility to be a leader and an influencer around community health issues? How can we change the environment, the influences at a community level to improve population health broadly, but indirectly your own population too, because they live there, or your future workforce that comes from that community? And here I really do want to get into the question of how employers influence the healthcare delivery transformation that needs to be a community endeavor. It's, you know, yes, employers pay a lot of health insurance, but it's very difficult for an individual employer, I don't know, even with a Goodyear and a major plant, to have enough influence on the provider community to really turn that ship around. So again, Paul, starting with, and you've told us some of your initiatives, I'd like you maybe to focus on what the community is doing in healthcare delivery reform issues at a community level. You heard about you know, patient-centered medical homes and accountable care organizations, more integrated healthcare, more focus on prevention. Any community-wide efforts going on in Rochester on that score?
There are several. Just as an example, as we talked about the infrastructure before, many businesses, we've been able to work with the 3 major hospital systems and the 2 health insurers, and we've been able to, in our community, figure out where you compete and where you need to collaborate. Other businesses do it all the time. And that's the real key here. I'll give you one example in high blood pressure. We have a community-wide registry around high blood pressure. Currently has a couple of 100,000 records in it, employees. It's information from all 3 hospital systems collaborating. And you won't find that anywhere, but we've been able to convince the people that are at our table that that makes an awful lot of sense. So we're doing that sort of thing, and lots of things. We created a regional health information organization several years ago because we needed to create an infrastructure. And we did that 7 years ago, and our RIO is now the most advanced in New York State and one of the most advanced in America. But it's got the support and seed money from business, as well as the traditional hospitals, health insurers, et cetera. That's top down. From the bottom up, we think that social issues are combined. We talked about the successes of Rochester. Its poverty rate is the 7th highest in America, so we have serious issues in the inner city. What do we do at the other end? My company alone, we've created programs where we currently have a program called Hillside Work Scholarship Connection, where 2,500 students in the city of Rochester participate. We give them all the tools they need to succeed. We give them jobs where appropriate, et cetera, and we've more than doubled graduation rates, as an example. More recently, we've adopted a high school in the inner city And we've worked with the parents as well as the students around not educational initiatives, because now we have longer school periods, school day, school week, school year, but we tie in healthcare, nutrition, wellness. When we surveyed the students, grades 7 through 12, the two things they seem most interested in were cooking and yoga. So if that's something they want already, we give it to them in clubs, which they didn't have before. We give that to them, and one of the things they had there, and we're going to be doing in the next year, is we've got lots of land at this particular location. They didn't even have teams. So we're going to put in gardens and have the children grow the food themselves. We're giving them a third meal a day and have them help prepare the third meal a day. So my sense is the education and healthcare, nutrition, exercise all come together around the school. There's plenty to be done, and lots of communities are doing lots of wonderful things.
Paul, a follow-up question, and that is, how important was it that the business community played that convener role in getting the other stakeholders together? Because we often find it's, very difficult for health plans or providers that compete every day, in the marketplace to actually collaborate. But if there is a convener like the business community that brings people together, it happens better, faster, quicker, and without the level of resistance that we see.
Right, and the collaboration of the CEOs I talked about before, we've been working on that for 7 years. It doesn't happen quickly. We built the infrastructure, and over time we incorporated the hospital CEOs as well as the health insurance CEOs as well. As we say, collaboration is very difficult to do, and it's difficult to do every day. It is not an easy thing, but you have to have a single-mindedness, and the business community is used to doing that. That's their focus, and at the end of the day, we're paying the bills. Again, when we're talking to the CEOs, we have one-on-one relationships with the CEOs, and so by getting them out of their environment where they have to compete fiercely against another hospital system, we show where there's areas to collaborate as well. And over time, we've been able to accomplish what we have in Rochester, and we've got lots of plans for the future.
Delia, Brent, quick comments on community focus, and then maybe we'll have a question or two from the audience, if that's all right. Our time got cut down a little bit, so we didn't have quite as much time. But Delia?
As in regards to community focus, we haven't reached out to the community other than the provider community, but that's something that is part of our future plan.
Great. Brent?
We've identified 14 different communication channels just to get the message out within our population. So some of it goes to the home, and with that we hope that it disseminates further. But more importantly, it's the way we're going to be approaching the health benefits. So you heard from Sam Ho earlier today. During his Pacific Care days, he talked about the quadrants. So it was the high quality, low cost quadrant where we wanted to start driving people. And that's where we're going to start to drive folks through our on-site clinics to make sure people are accessing high-quality, low-cost care, and making sure that people know that that's available in the community, because just because everyone seems to think their doctor is best, it may not actually show up that that's the case. So we want people to actually see what, and we're going to help them to help identify who are the better quality providers and who are able to do it at a more effective cost.
Boy, I'd love to talk about that one issue for the next hour, but let's go to questions.
Hi, thank you. My name is Linda Hermer. I'm with GWU and Neuroscience Now. I wanted to bring the panel back to diabetes per se. Something that I think needs to be talked about more is that work environments are sedentary, and that even for people with a normal weight, being habitually sedentary induces metabolic changes that promote the diabetes disease process as well as cardiovascular disease. And I'm wondering how open you are to, and one more thing is that as far as physical activity initiatives, the fittest employees tend to get involved in those the most. So I'm wondering what you all think about technologies that workers can use while they're at work. For example, starting with low-tech, therapy balls cost $25, and people burn 300 more calories per day and keep their core muscles and legs more fit. would you be willing to have them sit on therapy balls, or maybe you are already? On the other end, it's a little more costly, but for people who are, say, morbidly obese, there are treadmill workstations, employees can set the pace that they like, and they say that they actually like using them more than sitting, and they burn over 100 calories more per hour than if they were sitting. Not all of these have been tested in randomized controlled trials, but what are your thoughts?
Great question. Let's ask a health officer to address that.
So during my Pitney Bowes days, we had 2 call centers, and I put 4 of the walk stations in place. And we actually did a study and showed that people were actually able to be on the phone and do their work. And also it helped to get them more active. It also started to change the environment of the call center so that there were fewer donuts around, and it really starts to build on itself. And so at Goodyear right now, it's a really amazing time to be there because we're building a brand new headquarters. It opens up in February. So we're able to have those inputs on that, and we are putting a fitness center in there. We're going to have walking trails and things like that. But one of the things that's core to the way we do things is going to have people have to get up in the middle of the day to do their work. Get rid of the printers. People have to stand up and take a stretch break to go pick up their papers, and it's also a good environmental thing too. But you build those in. You build in times where people have to meet at different locations. Those are the types of things that do make a big difference, so thank you for bringing them up.
Great. Other questions?
Hello, my name is Laura Doyle, and I'm with Philips Electronics. Hi, Delia. We spoke about 4 or 5 months ago. We are just initiating workplace wellness and trying to help our population become healthier, and this has been a wonderful conference for us through my being able to be a part of it. We're at the very beginning stages, so you've all done so much in your areas. So we're starting with flu clinics and biometric screening and personal health assessment. I've heard a lot about screenings. How do we incorporate some of these things? There's so much for us to catch up, or would we dilute some of what we want to do if we try to do too much too soon? And we also have a remote population, so some of the post-work will need to be remote. So I don't know how effective that will be versus one-on-one coaching. So if anybody can address that.
Every wellness program, whether it's at a 2-person location or a 100,000 person location, is based around basically 6 different numbers: 0, 1, 5, 25, 30, and 100. So it's 0 is no tobacco use, 1 is flossing every day because of the connection between dental health and heart health, 5 fruits and vegetables a day or nutrition, 25 is body mass index at 25 or less, 30 minutes of activity a day, and 100% seatbelt and helmet use. Very simple messaging, and all the other bells and whistles that you're throwing at it are just kind of gravy on top of it to try to deal with those core issues. So you can take those and you can continue to communicate about them or throw programs at them, but that's really the core basis of the things that you're trying to accomplish.
I would add just one thing. We found successful programs start at the top. So if your CEO is talking and really when he goes out or she goes out to the employees and they see that they're trying to take this seriously, I always wear my pedometer, for example. We don't have as much of an issue because most of our employees are walking all the time anyway, but for our office people, we do have trails and that sort of thing. But at every level of management, it has to start with the top, and at each level, they have to understand and be a part of the process all the way through. And so it starts with leadership, just like any other program. I would start slowly, make sure you get it right. But to change your culture, it has to start at the top.
Well, I think that's a great ending point. I've got 3 zeros staring at me, so please join me in thanking Paul Sperenza, Delia Vetter, and Dr. Brent Palicki. This is now the break for lunch. I understand that there are box lunches outside. You just pick up a box lunch and bring it back here for the luncheon program. So thank you.